Welcome to another critical care lecture series. In this session, we'll be discussing fever in the ICU. Disclosures and disclaimers. I have no relationship with industry, and I have no financial conflicts. I do have a bit of bias to disclose actually, and that is that I do not treat fever indiscriminately. That is, I'm selective as to which fevers I treat. It's also important to point out the discussion for treating fevers within this lecture does not pertain to the acute neurologically injured or insulted or patients experiencing active cardiac ischemia. These populations need to have aggressive temperature management to minimize metabolic demand, tissue oxygen consumption, and cellular injury. So why a lecture on fever? Well, first of all, fever is very common in the ICU, so regardless of what specialty you work in, it applies to a large amount of your patients. And next, it's an area of debate. Do we treat fever? If we do, who do we treat fever in and at what temperature? And in addition, how do we even measure fever? What's accurate? What's not? There's a large amount of discrepancy in practice patterns, locally, nationally, and internationally. And at the end of the day, who's right? Heck, is there even a right? Lastly, the subject is on my clinical pet peeve list, so I'm always happy to present this topic. Before moving forward, let's go through our goals and our objectives of this session. So we'll discuss what a normal body temperature is. We'll go over fever definitions and its pathogenesis. We'll discuss how we accurately measure temperature in the ICU. We'll spend a bit of time covering fever etiology. And then when we choose to treat fever, how do we do it and with what methods? Lastly, I'll superficially review available literature throughout this presentation. If you want to take a deeper dive into the research, I've made sure to list citations on all applicable slides. Well, we all understand and probably agree that a normal body temperature is 98.6 Fahrenheit or 37 degrees Celsius. Some of us might not realize that there's normal variations in body temperature as well. There's actually a range for body temperature of 96.8 to 99.5 Fahrenheit. We also know there's variations throughout the day. We have a diurnal variation in our temperature that can flux between a half to a full degree Celsius. We also understand that the menstrual cycle may affect temperature as well. During ovulation, the temperature can increase to as much as 1 degree Celsius. And then impressively, doesn't quite apply to our ICU patients, but heavy exercise can actually increase our temperature by 2 to 3 degrees Celsius. One thing to consider in the ICU is environmental factors which may affect our body temperature as well. So this could be HVAC, heating, ventilation, and air condition. In addition, in the ICU, we have a good amount of extracorporeal technology. So whether this is renal replacement therapy, MARS, or ECMO, blood leaving the body can be affected by the external temperature within that room. I'd like you to ask yourself a question. In a patient that's not incurring neurological insult or myocardial ischemia, what do you feel is a significant temperature in the ICU? Anything over 98.6? Anything over 100, anything over 101, or anything over 102 Fahrenheit? I asked that exact same question to approximately 100 ICU clinicians. And as you can see here, the predominance of answer was anything over 101 Fahrenheit. But I do want to point out that a significant amount of the poll answered anything over 100 Fahrenheit, and some even answered anything over 102 Fahrenheit. With that, let's move on to the actual definition of fever or pyrexia. So there's definite variability in the literature, but the American College of Critical Care Medicine and the Infectious Disease Society of America guidelines define fever as any temperature greater than 101 Fahrenheit. Now there is a catch to that, and that catch is if your patient's neutropenic. So again, if they spike a temperature greater than 101 Fahrenheit, that is a fever. However, if they spike a temperature of 100.4 Fahrenheit or higher for greater than an hour, that's also significant for a definition of fever. A neutropenic patient has a reduced ability to form a fever, so this lesser threshold acknowledges this disability. There's other considerations to discuss as well. So a chronically diseased patient, heart failure, liver patient, CKD, immunocompromised, or even an elderly patient has a reduced ability to spike or form that fever. In addition, we know there's multiple medications that blunt the fever curve or blunt the fever effect. That could be acetaminophen, NSAIDs, and steroids. And lastly, while this lecture is about fever, we do need to point out hypothermia, especially in an infected septic patient. This is a critical finding, and some literature points towards an even more adverse outcome. A polar opposite is hyperthermia or hyperpyrexia, and this is defined as a temperature greater than 105.8 Fahrenheit. This is the critical thermal maximum. Think of denaturing proteins and cellular injury. These temps are usually non-infectious in nature and are brought on by other etiologies like drug fever, MDMA, serotonin syndrome, malignant hyperthermia, thyroid storm, heat stroke, and hemolytic transfusion reactions. It's important to point out that once we identify hyperthermia, the treatment consists of active physical cooling because antipyretics aren't effective because it's uncontrolled heat production. There's really nothing to do with the hypothalamus set point. Once we identify fever, it shouldn't be a knee-jerk response to work it up. Rather, it should trigger a targeted history, exam, and then only if appropriate, a workup. Because unfortunately, fever workups are often misguided, they're expensive, and sometimes it can actually have negative effects on the patient. Once a fever workup is deemed to be appropriate, we can send cultures, labs, and imaging studies. In regards to cultures, so first, blood cultures. It's important that we send at least 2 sets, anaerobic and aerobic, from 2 different sites. It's also important that these blood cultures are obtained with aseptic technique to avoid any contamination. And lastly, it's very important to fill the blood culture bottles as instructed by the manufacturer. If an insufficient amount of blood is put in one of those culture bottles, the sensitivity for the culture becoming positive is much lower. In regards to respiratory cultures, I'll point out that an expectorated sputum is of low clinical utility in the ICU. We would prefer a lower tract respiratory sample, i.e. a tracheal aspirate, a mini BAL, or a bronchoscopic BAL. Urine studies, we always want to make sure that we disseminate the difference between a colonized catheter and an infected urinary tract infection. And then lastly, when it comes to wound cultures, we want to make sure that the wound is truly infected, i.e. purulence, before we were to do a wound culture. With all cultures, it's important to obtain those cultures prior to the administration of antibiotics as long as there's not a delay in care. What's a delay in care? Surviving Sepsis Campaign defines that to be 45 minutes. Labs could include CBC with differential and LFTs. Imaging could be anywhere from radiographs to white blood cell tag scans. And then lastly, things that don't belong. Source control is important in sepsis. PICCs, central lines, and indwelling urinary catheters need to come out if appropriate. Okay, now we got definitions and a bit on workup out of the way, and next will be the pathogenesis of fever. Now, the pathophysiology of fever is a very complex process to understand, so I teach myself the KISS method, and it's really so I just understand the basics and understand how my treatment modalities work. So obviously here we have a brain. Within the brain we have the hypothalamus. Now, the hypothalamus is the thermal regulatory system for the body. The way I think about it, it's the body's thermostat. All thermostats need a thermometer. So there's 2 types of neurons for temperature sensing in the body. One looks out in the periphery, almost like a remote thermometer. And the other is the hypothalamus itself, almost dipping its toe in to understand what the temperature is. So the hypothalamus sets the thermostat. The sensory neurons report the temperature. And when necessary, the hypothalamus triggers the heat to turn on. It does this by 2 different ways: heat conservation and heat production. So an example of heat conservation would be vasoconstriction. The peripheries become vasoconstricted, the blood comes within the thorax, the core of the body, and this maintains heat. Then we have heat production, and one of the most powerful tools for heat production is shivering. Then we have fat thermogenesis, muscle and liver thermogenesis, an increase in our metabolic activity, and also behavioral changes. What are behavioral changes? We've all been at home with the flu. What's the first thing that we do? We grab a blanket, we cuddle up, and we turn on the fire. These are examples of ingrained behavioral changes when we have a fever or an illness. Let's expand on fever pathophysiology just a bit. First, we start out with a pyrogen. And what is a pyrogen? It's any substance that triggers a fever. So this could be a bacteria, a virus, a fungus. These pyrogens activate white cells, monocytes, macrophages. In addition, inflammation, hypoxia, and tissue injury can also activate these white cells. Once the white cells are activated, they can trigger the release of cytokines. And what are cytokines? They're small proteins that regulate the inflammation in the body. From there, prostaglandins are secreted, more specifically prostaglandin E2. Prostaglandin cannot penetrate the blood-brain barrier, so we have a structure within the brain called the organum vasculosum of the laminal terminalis. So this sounds like something out of Harry Potter, but I assure you it's a real thing. And what is this? It's a large fenestrated capillary network that surrounds the hypothalamus. So it's a capillary bed with holes in it, so it allows the prostaglandin to get through. So now it's able to penetrate through the blood-brain barrier and stimulate or trigger the anterior hypothalamus. The anterior hypothalamus, in response, changes the set point, and again, in my KISS method understanding, this is triggering the thermostat within our body. A fever can also be triggered from a CNS source. So the CNS can also release its own cytokines, and we see this from direct or regional brain injury, and a lot of us refer to this as central fever or neurogenic fever. Wrapping up on fever pathophysiology, we need to remember that fever is an evolutionary adaptive response. We also know that increasing the temperature actually increases resistance to infections. We see this in animal and in vitro experimental models. We know that fever, a higher temperature, activates antibodies, T cell activation. We already talked about the cytokines and the white cell activation as well. And we know based on laboratory models that many microorganisms are actually inhibited by this febrile temperature response. This is best studied in strep pneumoniae and Neisseria. Moving along, so far we've covered definitions and we just finished pathogenesis. Now we're going to move on to accurate ICU measurement of temperature. When discussing measurement of temperature in the ICU, I think it's important to understand what the most accurate way to measure body temperature is, so i.e. the gold standard. And on top of that, once we've identified the gold standard, what's the most reasonable and reliable and reproducible measurement tool? Just because we have a gold standard doesn't mean we can use that all the time. And then most importantly, what tools should we not use to measure temperature in the ICU? Let me first ask you, what's the most accurate way to measure temperature in a critically ill, intubated patient? 1, a PA catheter or urinary catheter temp probe. 2, rectal temp. 3, oral temp. 4, axillary temp. 5, tympanic. Or 6, an infrared temporal or forehead thermometer. Taking a look at our external poll results for comparison to your answer, we can see that the majority of folks selected a PA catheter or a urinary catheter temperature probe, and a few clinicians also said rectal. If we were to rate temperature measuring tools in the ICU from most accurate to not to be used in the ICU, we could use this graphic to guide us. So you can see the most accurate would be intravascular, i.e. pulmonary artery catheter, followed by bladder urinary catheter temp probe, esophageal probe, and then coming down in the acceptable, you would start seeing your rectal probe, your oral probe, and balancing right on acceptable to not use would be your infrared tympanic. Not to be used in the ICU, you see your axillary thermometer, your temporal artery thermometer, and your chemical dot thermometer. An important matter to point out, while rectal probe is an acceptable measure of temperature in the ICU, many hospitals have changed to a chemical dot thermometer for rectal temps due to transmission risk of C. diff. So the most accurate temperature measurements in the ICU are core measurements. So the gold standard would be the pulmonary artery thermistor. Thermistor is another word for thermometer. This again would be the gold standard. We know it's invasive. We don't use PA catheters in many patients these days. We wouldn't start by putting a PA catheter in somebody just to monitor temperature. Next would be the bladder or urinary catheter temp probe. It shows excellent agreement with the PA catheter. We all know the invasive infection risk from a urinary catheter in itself. Again, we would not put this in just to measure temperature. But if a patient has a urinary catheter in and it has a capability of temperature measurement, this is ideal. Next is the esophageal probe. So again, it's comparable to the PA thermistor and the bladder urinary probes. I do want to point out with esophageal probe temperature catheters, the placement is very important. It should be at 2/3 the esophagus. If it goes too deeper into the gut, you can see huge fluctuations in temperature, especially with free water flushes. Next in line would be rectal temperature probes. So these correlate very well within about a few tenths of a degree with the core temperatures. So these are handheld type devices, but the problem is, especially the one you see in the graphic here, there's a high risk for fomite transition with C. diff. So a lot of facilities have gone away from this probe and instead have used a chemical dot thermometer. Now there's a lot of question whether chemical dot thermometers are accurate. If you look at the manufacturer, they demonstrate that there's good accuracy. However, the literature is However, when you look at the literature, it gets a little shady. They don't compare correlation to the gold standard, i.e. PA catheter. So be cautious with its interpretation. Some of the other shortcomings would be that the rectal temperature is obviously unpleasant, but I think this is one of the least concerns of an ICU patient. We always have to remember there might be difficulty in positioning the probe at times because of stool impaction, and there's always a risk of trauma or perforation. Relative contraindications to rectal probe thermometers are coagulopathy, but most certainly neutropenic patients. So if you ever have a patient with an absolute neutrophil count less than 500, you should not do a rectal temperature. Moving down the line, we have an oral temperature probe. So this is accurate. It's very familiar. Hey, in an awake cooperative patient that's not intubated, oral thermometers are great. But we can't use it in an intubated patient. We can't use it in a patient that's mouth breathing. We certainly can't use it with somebody on high flow nasal cannula or non-invasive positive pressure ventilation. We also need to watch out for recent PO intake, i.e. cold water, followed by an oral temperature probe reading. So overall, oral temperature probes are great, but only in select patients in the ICU, definitely not the intubated patient. So now we start walking the line on appropriateness and maybe inappropriate. So we have an infrared tympanic membrane thermometer. Now there are actual direct tympanic membrane probe thermometers. However, these are painful and there's high risk for perforation. So this is why we use the infrared technology. It makes good sense using the tympanic membrane because the tympanic membrane and the hypothalamus actually share the same blood supply. However, you really need to use appropriate technique. And unfortunately, this is rarely done. In addition, we have to worry about wax impaction. This will affect how the infrared reading displays. The literature gets a little sketchy. There's some poor agreement with infrared tympanic membranes and PA catheters. There's really unclear accuracy, but in the same breath, this is deemed an acceptable method by the IDSA guidelines. I would yield some caution on this, ensuring that we're using this tympanic membrane infrared technology appropriately, and whenever in question, use another modality of temperature measurement. Now we move on to axillary temperatures, and let's just get this out of the way very quickly. This is inaccurate in the ICU, 2 thumbs down. Guidelines tell us we should not be using this in the ICU. Get rid of this in your ICU now. We then move on to even more inaccurate temperature measurement technology in the ICU, and that is a temporal artery infrared probe. IDSA guidelines tell us these should not be used in the ICU. Alrighty, so we've gone over definitions, pathogenesis, accurate measurement of temperature in the ICU, and now let's talk a little about etiology or causes of fever. So as we know, many fevers in the ICU can be from infectious sources. This include pneumonia, bacteremia, central line acquired bloodstream infections, C. diff, complicated wounds, empyema, CNS infections, even suppurative thrombophlebitis. Lastly, urinary tract infections. I'd like to spend a little more time on this topic. Catheter-associated urinary tract infections unfortunately are not rare, but fever in an already established ICU patient has a poor predictive value for urinary tract infection. We know that catheter-associated bacteria usually represents colonization. So bacteria in the urine is usually a colonization on the catheter and not an infection. We also know that catheter-associated bacteria is rarely symptomatic, and this makes sense. We're bypassing the plumbing. There may be a rarity of a suprapubic tenderness, but other than that, it's not surprising that these infections are not symptomatic when they are present. And again, a very interesting fact, catheter-associated bacteria rarely is a cause of fever in an established ICU patient. In addition, it's rarely the cause of a secondary bacteremia, and this even holds true for an immunocompromised patient. This is as long as the urinary catheter is not obstructed, the urological tract is not obstructed, the patient didn't just have a urological procedure, and the patient is not granulocytopenic. So a definition of granulocytopenic is an ANC absolute neutrophil count less than 200. With all this said, it's time for a good reminder to understand that the urinary catheter collection bag must always be below the level of the bladder. We also want to avoid any dependent loops that we see in the drainage tubing. Doing otherwise would cause reflux of urine and increase the risk for urinary tract infection. As we just mentioned, infection is a leading cause of fever in the ICU, but so is non-infectious causes of fever. In fact, there's a substantial amount of ICU patients that are febrile that are not infected. And there's a multitude of conditions and disease processes that cause fever in the ICU. Drug fever, acalculous cholecystitis, pretty much any type of ischemic insult to the body, ARDS, malignancy, hematoma, pancreatitis, venous thromboembolisms, thyroid storm, and vasculitis, just to name a few. So now let's briefly discuss fever of unknown origin. Everybody likes saying it, everybody wants to mention it in rounds, but very few ICU patients truly have fever of unknown origin. Taking a look at the criteria right here, you can see why. So it's a temperature of 101 or greater on several occasions, but this lasts 2 to 3 weeks, and there's no established etiology despite a workup and testing. When we do have fever of unknown origin in the ICU, it really revolves around 3 etiologies: infection, inflammatory or connective tissue disease, and malignancy. So the top players in the hidden infection, the fever of unknown origin category, would be TB, abscess, osteomyelitis, and culture-negative endocarditis. When it comes to inflammatory and connective tissue disease, we're talking Still's disease, arthritis, polyangiitis. And then lastly, malignancy. The quickest 2 that come to mind would be lymphoma and leukemia. However, it is also common in renal cell carcinoma, some liver cancers, and MDS. Okay, so we've covered some definitions, some pathogenesis, we discussed some on measurements, and now we just briefly reviewed etiology. Now let's move forward to treatment. First, I would like to ask you a question. In patients without a neurological injury and patients without active myocardial ischemia, when should fever be treated? Anything greater than 98.6? Anything greater than 100? Anything greater than 101? You should only treat high-grade fevers, or you need more information. So let's take a look at our external poll results. And as you can see from the surveyed population, the majority of folks said anything greater than 101. There were some folks that said greater than 100, a few that said high-grade temperatures only, and then a few that also said I need more information. So with that, one more question. Fever should always be treated. True or false? Again, we'll compare that with our external poll results, and you can see the majority of our surveyed population says false. But just to identify the variation in opinion when it comes to fever treatment, you can see almost 30% of the critical care RNs answered true. That is true, all fevers should be treated. So when it comes to talking about treatment of fever, we should ask ourselves many questions. Should we treat fever? If so, when and at what temperature? If I'm treating fever, I would expect that I'm probably trying to improve outcomes. With that, does it affect mortality? And are there negative downstream effects? The main players of our treatment would be acetaminophen, NSAIDs, and active cooling. Let's briefly discuss the pro-con debate of the treatment of fever in the ICU. So clinicians that are pro-treating fever all the time, they would say fever places an expensive metabolic burden on an already ill patient. With that, we know that fever increases oxygen consumption and it can potentiate cardiac dysfunction. And another point or another goal of folks that are pro-treating fever is that treating fevers will improve outcome. Now, if we flip the script and take a look at the folks that do not treat fever, they're the con debate to treating fever. First, I need to point out these folks aren't saying don't treat fever. They say be selective in who we treat fever in. These clinicians point out that antipyretics mask fever trend, which they do. They also point out that fever augments the immune function, which we've already discussed, and that fever inhibits microorganism growth. They're also concerned about the adverse effects of some of these antipyretic medications, liver and renal dysfunction, GI bleeding. And then we could get into the concerns with active cooling. So they point out that active cooling causes cutaneous vasoconstriction. It stimulates the CNS, the sympathetic nervous system. It increases shivering. Shivering alone increases oxygen consumption. If the initial goal was to treat fever to decrease oxygen consumption, and you're not appropriately medicating the patient while you're actively cooling, this could paradoxically increase oxygen consumption. And lastly, there's a skin injury risk, which makes sense. You're causing cutaneous vasoconstriction. The clinicians that favored the con debate further strengthened their argument by an article that came out in 2013, Association of Body Temperatures and Antipyretic Treatments with Mortality of Critically Ill Patients with and Without Sepsis. Granted, this was an observational trial. There was many limitations, even including how they were measuring the temp. But with that said, it showed that NSAIDs and acetaminophen use was independently associated with increased mortality in septic patients. In fact, it carried a 2 to 2.5 time risk of mortality when using these medications. The same was not shown in non-septic patients. Another unrelated concerning signal in this paper was that temperatures greater than 103 Fahrenheit was associated with increased mortality in non-septic patients. So now let's get into the actual treatment itself, treatment considerations and medications, and we'll start with NSAIDs. So first, concerning side effects in NSAIDs, obviously renal dysfunction and bleeding, but also cardiac thrombotic risk. There's actually a black box warning concerning patients undergoing PCIs and cardiac surgery receiving medications such as these. An historic study from Bernard et al. Demonstrated that giving an NSAID decreases prostaglandin levels, which we knew. It also decreased temperature, decreased heart rate, lactic acid, and oxygen consumption. And most importantly, there was no increase in renal dysfunction or GI bleeds. However, it didn't reduce the duration of shock or ARDS, and it did not reduce 30-day mortality. So if you take a closer look at this paper, it was a 455 population size, it was randomized, it was controlled, it was blinded, and when they gave ibuprofen, they gave it IV. So they gave IV ibuprofen 10 mg per kg, Q6 hours, times 8 doses for septic patients. And overall, the ibuprofen improved the numbers per se, but it didn't improve patient-centered outcomes. And then when we look at no increase in renal dysfunction or GI bleed, it's interesting. These patients weren't overly sick. They had a mean Apache score between 15 to 16, and they had a mean arterial pressure between 79 and 80. These weren't patients in overly overt shock, in which we worry about decreased renal perfusion or decreased mesenteric perfusion due to vasoactives. In addition, exclusion criteria for this paper included GI bleed and thrombocytopenia. And in regards to the paper showing that it decreased prostaglandin levels, well, yes, we knew that. So NSAIDs work off of arachidonic acid, which become non-selective COX inhibitors, which block prostaglandin activity. If prostaglandin activity is blocked, it doesn't reach the anterior hypothalamus, and the set point is not changed to produce a fever. The next treatment consideration is acetaminophen, and the obvious side effect of acetaminophen that we're concerned about in the critically ill is liver dysfunction. One thing with acetaminophen, we're always balancing how much is too much and how much is needed to reduce the fever. Literature shows us that 3 grams a day may give you mixed results and might not be beneficial. 4 grams a day have demonstrated a better substantial reduction in fever. And we know the safety limits are anywhere between 3 and 4 grams per day. We always have to take into our patients' comorbidities. So high-risk individuals would be ETOH use, malnutrition, low body weight, advanced age, or liver disease. These folks might need to be defaulted to the lower 3 gram per day dose. However, in a healthier patient, I would always go to the 4 grams per day if I was trying to treat fever. And despite billions and billions of doses of acetaminophen, we don't exactly understand how it works, but we know overall it reduces prostaglandin E2. Again, if we reduce prostaglandin E2, the anterior hypothalamus isn't stimulated to change the set point to increase the temperature. A more recent paper on acetaminophen was done in 2015. Acetaminophen for fever in critically ill patients with suspected infection. This was termed the HEAT trial. Patients were enrolled if they have known or suspected infection with a fever greater than 38. Right away, I'll show you that greater than 38 is not the adopted standard by the IDSA. Sample size was 700. This was blinded. It was binational. It was New Zealand and Australia. It was randomized and it was controlled. The intervention group received 1 gram of acetaminophen every 6 hours until either ICU discharge, resolution of fever, the antibiotics were stopped, or the patient died. The primary outcome was ICU-free days. Unfortunately, there was no change, no difference in ICU-free days. In addition, secondary outcomes of mortality at 28 days and 90 days showed no difference. So overall, treating patients in the ICU with acetaminophen and a fever did not decrease mortality. Moving on to further treatment considerations, active cooling. So within active cooling, we have evaporative cooling, which in the old days when we used rubbing alcohol and it would evaporate and cool the skin. We have conductive, which is the mainstay of today's technologies. This would include a cooling blanket or cooling wraps. And then lastly, intravascular cooling, which is usually more reserved for TTM patients. The known adverse effects from these therapies are again cutaneous vasoconstriction, increased sympathetic response, and a high risk for skin injury. Some concerns that need to be carved out in future literature is what about pain, sedation, and anxiety? These patients that are being actively cooled can be presumed to need to require more sedation and more analgesia. What does this do for increased vent time or increased ICU length of stay or even delirium? And what about shiver control? We would never think of cooling a patient on TTM without shiver assessment and shiver control. The same should go when we're treating somebody's fever with active cooling methods. We cannot allow these patients to be in pain, to be anxious, to be shivering, or have piloerection because they could have a paradoxical increase in oxygen consumption when your whole goal was to actually decrease it. You need to ensure pain, anxiety, piloerection, and shivering control. I have another question for you. So treatment of fever. Packing the patient in ice bags, is this a nursing intervention or a provider order? So taking a look at our external poll results, the majority of our critical care nurses said this is an intervention. Our providers were kind of 50-50 on that one. I have another similar question. So in the treatment of fever, cooling blanket or wrap, is this a nursing intervention or provider order? Our external poll showed an overwhelming provider order to utilize a cooling blanket or cooling wraps. Frankly, I find these results ambiguous. Both are external active cooling methods. Both can have negative downstream effects, but it appears because one is the actual device, survey participants feel that there should be a provider order. I would argue that the concern should be on both sides, ice packing and cooling blankets and wraps, and a provider should be involved with all these decisions. So let's look at some literature that specifically looks at active external cooling. This paper was from 2012. It was a French-derived study, fever control using external cooling and septic shock. It was multi-centered, it was unblinded, kind of hard to blind external cooling techniques, and it was randomized and controlled. It included septic shock patients on vasopressors, sedated, mechanically ventilated, and with a fever. They used external cooling for normothermia. They define these devices as either auto-cooling blankets, ice-cold sheets, or ice packs. Sample size was 200 and the intervention group was 101. And this was a very sick population. This population, if active cooling were to work, this would be the population I think it would work in. So the primary endpoint was a number of patients that had a 50% reduction in vasopressor use in 48 hours. So the primary endpoint showed no difference. However, there was 10 secondary endpoints, and many researchers might call this a fishing expedition. And these secondary endpoints included a 50% reduction at 2 hours, 12 hours, 24 hours, and 36 hours. They also looked at mortality at 14 days, ICU length of stay, and hospital length of stay. Remembering that secondary endpoints or secondary outcomes are hypothesis generating, and they should always support the primary endpoint or primary outcome. Essentially, there's a 50% reduction at 2, 12, 24, and 36 hours, but not 48 hours. There's a small reduction in 14-day mortality, but there was no significant change in ICU length of stay or hospital discharge. Interesting things to point out with this paper. There was no reported RASS or sedation levels or total dose of sedation needed within a 24-hour period. I would expect that these folks undergoing active or external cooling would need more sedation and analgesia. And while some of this patient population was sedated, mechanically ventilated, and ARDS, there was an increase of neuromuscular blocking agents in the external cooling group. And we all know there are negative downstream effects from neuromuscular blocking agents. And lastly, there was no discussion of ventilator days. One last thing, the outcome or endpoint of a 50% reduction in vasopressors in somebody that you're actively cooling. So I would expect that as I actively cool somebody, their SVR, their systemic vascular resistance goes up, and I could surmise that that would bring down my catecholamines, my vasoactive vasopressors. So a mixed bag of results, difficult to interpret, and a small sample size. So with that, what other data do we have on just antipyretic therapy? Antipyretic therapy in febrile critically ill adults. This included 5 randomized controlled trials, and it showed no effect on mortality. That is, treating fever with antipyretics did not decrease mortality. The next paper was a sequential analysis in 2015. It included 6 randomized controlled trials, antipyretic therapy in critically ill patients with established sepsis, and again, it demonstrated no mortality reduction with treating with antipyretic therapy in fever. And then lastly, in 2017, a meta-analysis that included 8 RCTs and 8 observational trials, antipyretic therapy in critically ill septic patients, demonstrated no reduction in 28-day or overall hospital mortality, demonstrated no change in shock reversal. However, it did reduce the temperature. However, it did not decrease the heart rate or minute volume. I found this very curious. I would interpret increased heart rate and increased minute volume as an indicator of increased oxygen consumption and increased CO2 load. But even by reducing the temperature on these patients, it did not reduce the heart rate or minute volume. So essentially a negative paper demonstrating that antipyretic therapy did not reduce patient-centered outcomes. All right, so we've gone through definitions, pathogenesis, measurement techniques, etiology, and we just covered treatment. Now let's wrap it up. So that was a lot of information, and you might be asking yourself, what's the correct answer? What's the answer to whether I should treat fever? My response would be that it is patient and disease process specific. So here are my personal clinical rules. 1. In a patient that has a neurological insult or injury, or a patient demonstrating active myocardial ischemia, I always treat. There's not a question to whether or not to do this. 2, the patient is miserable. If the patient is grossly uncomfortable from the fever, I treat the fever. However, when we step back and take a look at an ICU patient that's receiving analgesia and some degree of sedation, I feel this is actually a rarity. 3, the most important, I treat fever if there's evidence or concern for poor cardiorespiratory reserve that is not able to tolerate the increase in oxygen consumption, the increase in cardiac output, the increased CO2 production, and/or the increase in energy expenditure. An example of this would be a comparison between a patient demonstrating a 102 temperature that essentially offers no complaint versus a patient that has 102 temperature that's in atrial fibrillation, RVR, that I'm battling a heart rate of 160, 170. I would obviously treat the fever in the latter patient. And then lastly, number 4, I try to assign myself a ceiling temperature that I mandate myself to treat. I used to say greater than 104, but based on that paper in 2013, there's a questionable signal that mortality might increase in non-septic population patients if the temperature is greater than 103. Albeit observational data, there's at least somewhat of a signal for guidance. So number 4, temperature is greater than 103. So let's wrap this session up on fever in the ICU. We know that fever is greater than 101 Fahrenheit. We know in a neutropenic patient, a temperature of 100.4 for greater than an hour is also significant. We know that fever should lead to a detailed evaluation and assessment, not a reflex workup. We now know how to accurately measure temperature in the ICU, get rid of your axillary and temporal temperature monitors. We always need to search for our differential of fever in the ICU. Infection is high on the list, but now we understand that there's a substantial amount of ICU patients that are febrile but not infected. I think we all can agree that fever is a defense mechanism and that treatment is not required in all patients. That concludes this educational session on fever in the ICU. If you have any questions or feedback, feel free to email me. Thank you for your attendance and time.